Hello, sir. Should we begin?
And then start. Okay.
Yes, sir. Hello, everyone, and welcome to today's session. And this is the ninth part of a week-long series of webodontia. And these events are brought to you by the Rotaract Club of the Caduceus, an organization of youth medical and paramedical students. The webodontia is a week-long event with educational webinars blended with fun activities. Before we begin, I'd like to mention that a recorded version of this webinar will be available on our YouTube channel, and the forum for questions will be open at the end of the webinar. The feedback form prevailing certificates will be provided in the chat box on Cisco WebEx as well as YouTube Live. And with that being said, I'd like to introduce today's honorable presenter, Dr. Sandesh Mayekar, the father of modern dentistry in India. I doubt that he needs any introduction by us today, but just for the sake of a formal introduction, Dr. Mayekar is a phenomenal teacher who selflessly shares his years of aesthetic dentistry experience to dentists throughout the world, so that everyone can perfect the art from the master himself. And he is also the sole master of TMD and occlusion and believes that there is no dentistry without occlusion, which is what he will be sharing with us today. We are elated to have you here today, sir, among us, and we
Thank you
couldn't be
very
more
much.
excited to hear. Yes, sir.
He is qualified as an MDS from Mumbai, MS from the USA, and postgraduate in temporomandibular disorder and orofacial pain from the Tufts University in the USA in 2008. Honorary consultant advisor to the India Armed Forces Medical Services, Government of India. He introduced aesthetic and cosmetic dentistry into India, launching the Indian Academy for Aesthetic and Cosmetic Surgery, IAACD. He was past president of Asian Academy of Aesthetic Dentistry, AAAD. He was an active member of the Dental Council of India for 7 years and its exclusive council for 3 years. He is currently the member of the American Academy of Cosmetic Dentistry and American Society for Dental Aesthetics. He is visiting faculty at the University of Buffalo in New York, USA, and the Department of Restorative Dentistry at New Jersey School of Dentistry in USA. So that's it. And over to you, sir.
Thank you very much. I'm glad that I'm speaking to fellow Rotaractors because I was a Rotaractor and my career was built up because I was a Rotaractor. When I was in third year BDS or second year BDS, I joined Rotaract Club of Government Dental College, Mumbai, and our host club was Bombay, Maine, one of the richest club in the country. And when I used to go to Taj Ballroom for the meetings with our parent, that is Dr. Prem Prakash, the renowned orthodontist, and others, I used to be just love that atmosphere in Taj and get to know a lot of things. And one of the best things what I learned from Rotaract is I was a very shy person. I never used to speak even in my classes. The questions used to be asked, and even if I knew the answer, I never had a guts to raise my hand and answer the questions. My classmates will vouch for that. That Sandesh was a very quiet person. I had a complex of speaking, so that's what the ice was broken when I joined Rotaract and I became the president and secretary and then the president. So you have to come in front of the audience and speak. So that was the first break I got to speak to fellow Rotaractors. Rotaract again taught me to conduct a lot of dental camps, which we conducted all over Maharashtra. And what Rotaract did for me is to communicate with people at large, especially low economy. And from there, I learned if you can convince the low economy person to do dentistry, you can convince anybody to do the dental practice or do the dental work in their mouth. That's what I learned from there. We should conduct camps in Adivasi areas and all. And then what I learned again from Rotaract is to do extractions in conditions where I have removed the upper root piece with a lower root forceps because the other root forceps was in sterilizer. So that time it was boiling sterilizer. So the technique what you use, the jugaad what you do, you learn a lot of things from there. So I owe a lot of things to Rotaract, and when I came to know it's a Rotaract group which is conducting, I said I'll be there. Then my ambition to become a Rotarian, of course, I became Rotarian. And then when I was supposed to be president of Rotary Club, I ran away from there. The reason being, I didn't want to spend a lot of time on weekends to do a social service, which can be done by any businessman. As a Rotarian, I wanted, as a dentist, I wanted to spend a lot of time to share my knowledge with fellow dentists, which is also a social service. So I left that Rotary Club, Rotary Uptown, and then 4 years back, my wife got an opportunity, invitation to become a member of the club, which I wanted to become is Bombay Main. So today she's a Rotarian, Bombay Main, and we are in charge of Rotary Dental Clinic, which we run at Ray Road in Mumbai. So that's what my connection with Rotary and Rotarians, and I still believe in all the fortes of Rotary and other things. And well, that's the Rotaract Club, and I'm very happy that all of you are conducting this type of webinars and getting education and doing some social service. One of the things, other things what Rotaract taught me, I'm just sharing this Rotaract first because you have to look onto that angle also. So one of the things what Rotaract taught me was to approach people. Don't be shy of approaching. Don't presume that people are going to say no. When you ask somebody 50% yes, 50% no. If you don't ask, it's 100% no. So I learned from there when we conducted a charity show in 1977, 78, when I was final year, I think, or intern, CA, what we call. And I went to, I still remember everything because that's the memory. I went to a theater called Maratha Mandir in Mumbai, and I still remember the name of the movie which we did the charity. And you don't laugh, the name of the movie was Udhar Ka Sindoor with Jitendra and Reena Roy as a heroine. So there I learned, he fired me that I didn't get permission, police permission, this. And I just looked at him. They were little, sort of my eyes were a little watery. And then he realized that he doesn't know anything. I said, Mr. Desai, I'm a dentist. I'm just budding dentist. I'm not even got my dental certificate. and doing this for charity, for social work, etc. And he helped me out totally. So, point to tell you is that don't feel shy of asking if you genuinely feel that you need a help from somebody. And well, if he says no, fine. Don't get hurt. If he says no, no, fine. But one has to be approachable, and that nature of mind that imbibed in me so much that in my practice today, I can talk to I've got do a little bit of charity work, chauffeurs, drivers do free of job till industrialists and film stars. So speaking becomes normal to them. You are genuine with them, and that's what is very important. That you are not personal bias just because somebody is rich. You speak in a different way, and somebody is poor. You speak in a different way. So in Rotaract, I learned that even a poor person is also a human being, and you have to respect him as a human being and not to respect the materialistic value of the people carry with them. So that's the basic road track which I have come up through. So it's nice and it's very, I'm very happy to be with all of you. And being 85% to 90% students, I will speak on my side, which I speak to international people also. But I'll try to make it very simple for you people. So I'm just going to share my slides now. Yeah. So usually I start this lecture, in our Hindus, we say Sri Ganesh. Anything new thing we start with say Sri Ganesh. And the reason we say Sri Ganesh because Ganesh head inspires us, the big head inspires us to think big and profitably and think profitably. The big ears prompt us to listen patiently to new ideas and suggestions. The narrow eyes point to deep concentration to finish tasks in hand well and quickly. The long nose help us to poke around inquisitively to learn more. And the small mouth reminds us to speak less and listen more. So it's apt that the head of Ganesha teaches us a lot of things. And that's the reason from kindergarten till any new activity, we always say Sri Ganesh and we start our activity. So that's what is. Now, this is the face which I want to show, but the topic for today is, let me put this off. Okay, topic for today is occlusion is dentistry and dentistry is occlusion. And this photograph I'm showing because you will be surprised, and I'm surprised, pleasantly surprised, that she was my patient for since 2000, this is 2020. So about 16 years, she was my patient, or 14 years, 2006, she was my patient. And suddenly she disappeared and did her job in Dubai with famous dentist who was always on Instagram that today I'm here, tomorrow I'm in LA, third I'm in New York and all. And then subsequently she came back and she is doing job with us. Now she wanted to come today. I said, come tomorrow. I'm doing a webinar. So you can see the occlusion on the right hand side. That's what is very important in our practice. That without occlusion, you can't learn dentistry. These are the different angles when you do smile and occlusion. You don't have to see the only facial, but you have to see all over, which is very important. And that's what is been seen that different angles, and the person should look nice in different angles, not only the front view. So that's what about her face. And this is my book, which is very important for patients, and most of the dentists are also buying it. I've written the stories about each chapter carries a story from TJ to even pediatric dentistry and aesthetics and implant and third molars, etc. So this is something which I've spoken about, which if you read, you'll get to know about even the marketing part and how to manage the practice, etc. So this is a very important slide. When was the last time you did something for the first time? As a student, you should always keep this in mind. Because once you come out and practice, you do some jugaad, you do something new. And this keeps you as an innovative person. Who are the people who have written your books? The people who have written your books and no one that human beings like you and me. So when they wrote the books, First, what they did something new. Then they did it again and again. Then they published a paper, and then they wrote a book with evidence base. So you should also think now, from now onwards, maybe with your experience after 15, 20, 30 years, you can write a nice book. Don't try to write a book. There are many of my colleagues who wrote a book just after graduation or doing 5 years of aesthetic dentistry or something. There, what you write is copy paste, only 10% of yours. You should write something which should be maximum of yours. Copy paste is actual facts. So, this is one of the important slides. The next one is also very important. Better late than never. That's what we always say. But never late is better. As a student, अरे बाद में पढ़ेंगे, this chapter will, do it later on, we'll do it later on. I've done that, and then you put some chapters as an option. I've got 8 questions, I'll write 5 questions, just, like put an option. But when a patient comes for your treatment and the knowledge has to be from that chapter, you have missed it, then there is a problem. So you should know everything, you need not do everything. So it's better that even in continuing education, whatever you're going to learn, don't postpone, do it in time. That is better than to postpone. This is what I'm going to speak about is function, not the smile design. There's no point in speaking to you about smile design because you are not going to implement what I'm going to teach you today. What I'm teach you about smile, but function, occlusion, you have to know. The reason is very simple. Without function, well, function, the smile or anything is gone. In this COVID time, I was asked, like you are supposed to do emergency work. I said, what's the definition of emergency in dentistry? Get over. People say, oh, pain in the tooth and the root canal and swelling, etc. For me and for you, the emergency is when patient can't eat. Patient has to eat, whether it's with pain, emergency with pain or without pain. If somebody's denture is broken, that's emergency, even if there's no pain. So in dentistry, we are so lucky that everything is emergency, except maybe to do laminate veneers. But that becomes emergency now for us because somebody's shooting is starting tomorrow. So emergency is where patient need to eat, and without eating, nobody can survive in this world. So all the youngsters, I've just read I heard YouTube by one of my close friends. Oh, dentistry has gone this and that and that. I said, hey, you did a biggest mistake. You did a mistake of doing this video YouTube for dentists. They already joined dentists. So why are you discouraging them? If at all you want to tell that dentistry that too many dentists, etc., talk to 12 standard people. Talk to their parents if they don't want to join dentistry. But that's your view. But let's take the practical view. The practical view is that we are in the best profession because जब तक खाना खाना है तब तक दांत की जरूरत है. जब in this world from the birth to death you want to eat, and till such time you want to eat you require teeth, and if you require teeth you have to maintain the teeth, so you require a dentist. So point here is I don't need a pediatrician. You don't need a pediatrician. I definitely don't need a gynecologist. But dentist, everybody needs it. My work is going on. So dental work is like a garage where servicing of a car has to be done. So when servicing has to be done, patient has to come irrespective of pain or no pain. And we are the dentists are only in the profession. If paramedical, other medical people are listening, you have to tell them that we are in the profession because everybody needs it. I can tell people that you come to me. A cardiologist can't tell me, Dr. Mayekar, if you get heart attack, come to me. Or an oncologist can't tell you that if you get a cancer, come to me. But as a dentist, I can tell them, come to me. And the second and the most important reason today that 75% are females. My daughter is a dentist, and it's the best profession for females. If they want to take a married leave or maternity leave or this leave, they can take a leave and come back, and patient will come back. And lastly, before I go to actual occlusion, ask yourself how many MBBS females are practicing and how many BDS female dentists are practicing. You find out. And for males also, for male and female and every dentist, who earns more, a BDS or MBBS? That you find out. So now let's go on to occlusion. So learn ABC, you can make sentences. Sorry. Learn ABC, you can make sentences. If you learn sentences, you can't learn ABC. That means what? Don't listen to somebody and practice. Today is a time where you are in first, second, third, final BDS intern. Today is a time to learn ABC. And that ABC, if you learn, you can make sentences. If you learn something, okay, I'll just pass and then go ahead. No. Passing is, is important, but understanding the subject is very important. If you don't understand the subject, there's no point in getting gold medal. So understand the subject, which is very important. There is no escape for dentists cannot repair, move or remove teeth without being involved in occlusion. If you don't know occlusion, you don't know dentistry. So occlusion is very, 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 very important. So you can't do anything in dentistry without understanding the occlusion. This is my guru, Gordon Christensen, and he said human dental occlusion is one of the most confused and controversial area of profession. And I'm convinced that occlusion is constantly changing and dynamic state that is almost never the same day to day. People don't understand occlusion. Students don't understand occlusion because teachers don't teach them occlusion. I'm not blaming them, but I'm telling you the fact. And teachers don't know the occlusion because they read from the books and teach you. The authors who have written the book, they don't agree with each other. They agree to disagree with each other. So that's the reason we have got Dawson theory, Frank Spear theory, LV theory, this theory, that theory, etc., etc., etc. But friends, according to Gordon Christensen and according to me, I have done my TMJ, occlusion is dynamic. And the reason for occlusion is dynamic because occlusion is not seen on the articulator. Occlusion depends on muscles of mastication. And the muscles of mastication, if the muscles go into spasm or muscles are relaxed, the occlusion changes. So it's always dynamic. So you have to understand that your occlusion is not only teeth to teeth, is how teeth are meeting because of your muscles of mastication. And really thank those who are listening should thank the organizers, the host who gave me this topic, because if you understand now what is occlusion, what it is, how muscles are also involved, you will not take that Orban chapter in second BDS. You got chapter on muscles of mastication, which you have it in third final BDS, and we read only to pass. Those who are in final BDS or those who are interns who are listening to me, if I ask them, tell me the definition of centric relation, and you will get, oh, what should be the definition? You will mug posterior most position, etc., is different. So that's the theoretical definition, but you should know the practical definition. So here you can see forces of muscles, occlusion, contact. It all depends on the forces of muscles, which is very important. The resistance of tissues and restoration. So when you close, see, upper jaw is fixed, only lower jaw moves. So when you close your mouth, this is what happens, the forces. So what are the forces? And these forces are very, very, very important. I just want to put this off. You can see this particular aspect, the tooth is sensitive because this is in malocclusion. You can see the forces here. You can see the forces. This is normal, and you can see here because the chemistry of the teeth is weak, because of the forces, what we call parafunction, you can see the cusp are gone and it's become flat. That is very important. It has become flat. Then you can see what happens with malocclusion. The periodontal, sometimes the teeth are loose, you feel there is a periodontitis. No, it's because of occlusal problem. The gums, because of the occlusion problem, the teeth are shaking. You don't have to do scaling and root planing and etc. Just check the occlusion. So it's involved in perio also. And lastly, sometimes you see the teeth fracture or broken. This is what happens if there is a malocclusion. The resistance, the force is too much. So this is occlusion contact, which happens because of the muscles of mastication. This is also very important. Magnitude of force. Now, this magnitude of force is also very, very, very important to see. What is the magnitude of force? When they come and touch each other, this is the magnitude of force. So you can see the muscles. These muscles are strong. You can see the magnitude of force going on to the upper teeth, the impact. And that is very important. And that depends on how the masseter is. How is the masseter? See this actress, her masseter. If any one of you having a strong masseter, start wearing night guard from today. Because once your occlusion takes place, any restorative material you use on the occlusal surface is going to damage the opposing tooth. So these masseter muscles are very, very, very important to see that these masseter muscles are strong. You have to take care from now. Then comes again the frequency of forces. So how many times somebody is clenching their teeth, grinding their teeth at night, and the direction of forces. So this also matters a lot. So when you are learning your carving, you have to learn total anatomy, the importance of carving and importance of your first BDS. Understanding the muscles are very important, so you know what is occlusion from the muscles. So this is what are the few points for youngsters to know. Number of contacts. Now these are very important. How many contacts? If the surface is flat, there is a flat contact. The transmission of forces are different on the flat surface, and transmission of forces are different when you got an anatomical tooth. So anatomy is very important for you. When you read Wheeler, when you carve, during our days, nobody told us the clinical implications of the anatomy of teeth. But this is a clinical implication. Where are the contact points? Why in second BDS, I mean third BDS, final BDS, they say that carve marginal ridge in your amalgam, because contact point is on marginal ridge also, working cusp and marginal ridges. So here you can see the working cusp and the marginal ridges, the contact points, which are very important to understand. And then movements of the teeth related to difference in wear characteristic of restorative material. Why silver has become, I am an aesthetic dentist. I love composite. But wearing of composite is faster than wearing of your silver amalgam. So amalgam today is the best material, but aesthetically is not so good, because the wear and tear of amalgam is very close to wear and tear of enamel. So that is very important, what material you're using. Today, when you tomorrow you become your dentist, people are talking of zirconia. Zirconia is a worst material. A technician says that you hammer my crown, it will never break. Arey yaar, it will break my opposing dentition, na? So that is very, very, very important. This is silver, this is composite, this is ceramic, and this is all ceramic. So wear pattern. So what you have to learn in dental material when you're an undergrad student is practical knowledge, the wear pattern of your restorative material compared to enamel. That is the most important aspect to learn. Then come periodontal disease. If someone has a perio, you don't only do perio, you have to adjust the occlusion first. Because the perio and occlusion, if there is a malocclusion, if the teeth are touching first, the teeth are going to move, especially anteriors where the labial bone is very thin. So those who are in third year and final year, if they're doing perio cases, check the occlusion before you do scaling, etc. But by the time the next appointment comes, you still feel there is a problem because of traumatic bite. So occlusion lies there also. Tooth extraction and not replace in time. The biggest problem what we are facing today is tooth extraction and not replacing in time. So what happens exactly? This is a tooth extracted and not replaced. Now, even Rotaract taught me this. Even in poor people, you should try and do root canal. If a poor guy can't afford root canal, he will never afford a replacement. And if a 9-year-old or 10-year-old or 15-year or 20-year-old misses first molar where the chewing capacity is 62.3%, and if this tooth is gone, the upper tooth is useless. And as a student, I'm telling you what simile you can give is scissors. You require 2 hands of the scissors to cut, so posteriors are to eat. If one hand is gone, this hand is useless. And then what happens if you don't replace? See what happened to the shifting of the teeth? Occlusion becomes malocclusion. And when this type of malocclusion comes in, I've got an article which says one tooth not replaced in time can give you headache, neck pain, shoulder pain. So imagine there are lots and lots and lots of people in this world whose teeth are not been replaced, having headache, neck pain. They go to neurologists and doctors and taking medicine. Take the occlusion. Get the occlusion properly, you won't get any problem. How do you compare this occlusion and other side all teeth are there? This occlusion can be compared when you're walking in one shoe, on the heel there is some problem, the second shoe there is no problem. What will happen? And that exactly happens here. So dental caries. Now we dentists are supposed to be expensive, but we are not expensive. Who makes it expensive? If patient goes at this stage, they don't have any expenses. Small decay X, big they don't go for 1 year, big decay 2x, bigger decay 5x, root canal 10x, crown 20x, implant 50x. Who made it expensive? Patient made it expensive. And the moment there is a problem like this, the occlusion is gone for a toss, especially when you look at class 2 restoration, class 2 cavities, because your occlusion points are on the marginal reaches. So that is the problem. So caries can change the occlusion to malocclusion. So this is very important to explain the patient. And when you do restorations, see that there are no high points. You have failed if you keep the high point in amalgam when you do a class, operative dentistry exam. So there should not be a high point at all on a lateral excursion movements, on vertical bite, nothing. So what is plate teeth? Improperly contoured restoration that are too thick on the lingual of the upper anterior teeth, or over-contoured over restoration are common cause for splaying. Splaying is what? Teeth become spread like this, moving. Now what this is showing you, this is about the occlusion again. Let me go back. So what is this telling you? This is telling you that the anatomy, when you carve your upper anterior teeth, the cingulum fossa is very important. And when you carve your lower teeth, the labial surface is very important. And that is the importance of your carving in occlusion. And that you have to keep in mind, otherwise there will be a problem. Wear teeth caused by parafunction. What is parafunction? Bruxism, etc. The teeth wear, if the teeth wear is malocclusion, occlusion is gone. And iatrogenic dentist, friends, our colleagues, including me, I must have done a mistake. Iatrogenic means what? Well, our technician doesn't give cusp and fossa, they always give flat surface. This is what they get, flat surfaces, and you have a problem. These are parafunction. Or when you do restoration, don't carve properly, make it flat, then the occlusion is gone. So that's the occlusion which you have to keep in mind. Erosion of enamel. Bruxer produces invagination of incisor enamel. Why? Because when you grind your teeth, left, right, you wear. Attritional wear. Posterior teeth are deflective incline interference with centrifugation. What is centrifugal? I'll come down later on. More often caused by forward slide of the mandible during closure for maximum intercuspation. You people can try it who are listening to me. Close your mouth and bring it forward. If the surface is flat, the teeth are going to move forward. The moment teeth are moving forward, the pressure of your masseter muscle or occlusal muscles are going to wear the anterior teeth. And that's going to cause further problem for your guidance. Orthodontic treatment. Orthodontist orthodontology is a very, very difficult branch in dentistry. Why is it difficult branch? I want to see orthodontist who gives me exact cuspal relation at the end of the treatment. It's not orthodontist fault, it could be the fault of the patient also. So when there's a compliance of the patient involved in any treatment, I'm scared of doing that treatment. If you do root canal, where there is no patient involvement. If you do extraction, there is no patient involvement except post-operative instructions. So orthodontics, I told you my Rotarian godfather, Dr. Prem Prakash, who was our guide, who was our host, in 1980, how many years back? 40 years back, he was charging 50,000 rupees for an ortho case. Today, the orthodontists are charging 25,000. Imagine 40 years back. But he's finishing. I've got his patients. I've seen his patient, and one of my associate working with me was here. His patient, perfect occlusion. Finishing is too good. What we are lack today is finishing, not only in ortho, but in our restorative material also. And that finishing we lack because too many people want to do a shortcut. Please don't do that. Tooth and restorative proximal wear, class 2 composite. I hate. I want to see any dentist having proper occlusion in class 2 composite after 5 years. Why? Because if you see, there is a slight movements on chewing, and when you chew, there is a slight movements. The wear and tear takes place, and the occlusion is disturbed. And then there is a diet. Well, you people might not be drinking wine, but colas. So this is what happened with colas or lime juice. I want to become thin. My stomach has to be clean. And so many people have lime juice for years together. Is acidic. Colas is acidic. This also erode nerve. And see what happened to the lingual surface of the upper teeth. What happens to the occlusal surface and what happens to the buccal surface. Now, these are all very important for occlusion. Occlusion is not intercuspation only. Occlusion is anterior guidance, which is very, very important. If you are in third year, final year, if you are doing dentures, after jaw relation, you always adapt or align the anterior teeth, canine to get a guidance. Once you get a guidance, then you put the posterior teeth. And that's what is full mouth rehabilitation. Traumatic accident, skeletal differences are always there. So I don't want to speak much. Destroyed dentition. I mean, this is destroyed dentition. You can read what it is. But you have seen a lot of people because they don't go to dentist till they get pain. And the whole dentition is destroyed like this. This is what his bite is. This is what is on Facebook and semi-adjustable articulator. Wear and tear, extractions. So what you see in the plaster is the correct occlusion has to be on correct occlusion, but now it has gone down because of wear and tear. You see so many patients because they don't go to dentist at all. So friends, that was occlusion. That means from first BDS to final BDS, you should know anatomy very well, and you should know masticative muscles, and not only those muscles which open and close, that is your masseter temporalis, pterygoids, medial lateral pterygoids, and your myeloid muscles. So they all muscles are involved, but most important muscles are sternocleidomastoid mustard and trapezius also. Now you can see this car. I'm just giving simile. You can see this car, old car when we were students. We used to do silver fillings. Later on, Suzuki and Honda Suzuki came in. We started doing composite restorations. 80s. 90s, we see BMWs and Mercedes coming in. We went into from metal with acrylic. We went to PFM crowns, full PFM crown with metal PFM. That is ceramic to metal. Those time we had Mercedes in India. Then we got Audis and Porsche in India. We started doing metal-free restorations. That doesn't mean if any dentist start his practice with metal-free, immediately they will get Audi or Porsche. No, that's not a simile here. Simile is automobile industry changed and our dentistry changed. Technology there changes and our dentistry changed. This is what we did. We started doing full mouth rehabilitation with implant prostheses, etc. We have Bentley and other big cars in the country. We have got CAD/CAM technology in India. Today we are at this stage in India. We see on Sundays we see Formula One, Ferrari. So what is common between Fiat to Ferrari? The interior has changed. The machinery has changed. But the common is the tire. The tire is round, it has not become square. The tire is the one which takes Ferrari and Fiat forward. The movements of your cars are because of these tires which are round. And the simile to our mouth, the movements of your jaw is because of your masticative muscles, which is very important. Opening muscles, closing muscles, and positioning muscles. So, friend, occlusion is because of muscles of mastication and not just anything like they're joining with each other. Then you see a joint here. When you see a joint, a TM joint, this is centric occlusion, this is centric relation. Here you can see muscles and spasm, and this is not in centric relation. So muscles of mastications are very, 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 very important. So before starting any restorative material in anteriors, restoration in anteriors, it is absolutely critical that the planning stage include knowledge of masticative muscles. I'm glad I'm speaking to students who will give importance to muscles before they go out in practice. Then interrelationship of teeth, TM joint, muscles and supporting tissues, and causes the effect of occlusions. Friends, is there any 3-year course on a particular, say, tooth? You have perio, etc., but there is a 3-year course only on TM joint. And TM joint gives you occlusion, gives you to one different aspect, which I'm going to talk about it, to give you a boost. The dentistry is not only during our time was scaling, filling, extraction, dentures. Today we have got so many things to do, but we are going to add few more things now. Now here you can see when the teeth meet each other is called centric occlusion, and the relationship of the jaw is centric relation. Now here is a joint, the muscles are attached to the disc here, and the joint moves. When it moves, you can see here when it moves, it's not only hinge joint, it opens and then goes forward. If it is only hinge joint, what would have happened? The ramus would have gone behind and it would have blocked your airway space. But God has done something which has got eminence here, and you can see it comes forward like this. So that's the occlusion which is very important to understand. So what is the definition of centric relation? A properly aligned condyle disc assembly in centric relation can resist maximum loading by elevator muscles with no sign of discrepancy. What are elevatory muscles? These are the elevatory muscles which are closing. Can you see these are the red ones? Here, there is a pain, that means this is not in centric relation. Your muscles are not in spasm, this is in centric relation. Simple clinical definition. While chewing, if I get pain here, that means I'm in not centric relation. Second definition of centric relation is the condyle position that permits interference-free occlusion. So when I open and close my mouth, there is no interference, which is very, when I open here, open, it goes forward, come back, and there is a problem here, there is an interference, there is no interference. And when the muscle goes to spasm, the disc is moved forward, you got clicking, etc., etc. So we'll speak more on interference, etc., to make you understand how occlusion is very important. So this is what lateral excursion, canine guidance or posterior rise, and anterior guidance, most important aspect. If there is any interference in canine guidance and anterior protrusive movement, the occlusion is gone for a toss. People only see occlusion in the posteriors, but the result of occlusion in the posterior is because of anterior guidance. And that is very important. Friends, today, actually today, last couple of them today, we did the anterior from one of very famous, I can't take the name, film star. Her TV serials are coming up, etc. We did anterior before the first. Now we are doing posterior and the demand is only do upper. I said, hello, we can't do only upper. Our anterior guidance are very important. We can't only do one arch, we have to do both, everything. Well, adamant. So what she's going to face, I'm going to tell you. Now this is a case, a full mouth case. Can you see discolored tooth, missing teeth, a deciduous tooth? This is a deciduous tooth, missing teeth. All this thing is a full mouth case. What we did, you can see now here, and you can see the full mouth. You can see the discoloration is gone, the laminates have been done, extraction has been done, replacement has been done. Let's see the closer look. Can you see the midline is gone? Midline is gone. When the midline is gone, that means either teeth are shifted or mandible is shifting. How do you know that? Frenum attachment. You look at the frenum attachment, when you close your teeth, mouth, and there is no discriminate frenum attachment, that means teeth are shifted. But when you're closing and the mandible shift on one side and the frenum is not above each other, shifted, that means mandible has shifted. And in her case, she's chewing only from one side, so mandible has shifted on this. So you deprogram the muscles to get proper occlusion, get the midline, and then replace the teeth. So that's what has been done in this case. We did implant prosthesis, etc., but we got a proper occlusion. And that's what is the case. So this is what, in short, so when you do any occlusion, the essential principle of organic, now the organic word has become very famous. First is anterior guidance. Next is you see the centric relation in anterior guidance. Third, this is the anterior guidance lateral discussion that we are supposed to see. Next, is there any problem with the slides? Somebody is asking me the questions.
No, sir.
Any problem or is going fine?
It's going perfectly, sir.
Okay. Next, we see the vertical dimension. So once we get the anterior guidance, you can see the vertical dimension. And then the most important aspect is bilateral occlusion stability. You can't have one. You have to have both the sides. So bilateral symmetry is very important. Why? Because TM joint is the only joint which moves bilateral. I can move right hand, left hand, but TM joint both moves together. If there's a problem on one side, there will be a problem on the other side. So that is very important, is to move on both the sides. So friends, one tooth missing on one side can cause the problem on the other side also. So occlusal problems, if there's a problem in occlusion, don't look at only one side, look at the holistic approach. One of the key point to take home, friends, is holistic approach. Occlusion and dentistry is holistic approach. That's what you're supposed to see. So this is what we saw the occlusion in this case. After full restoration, we saw the points touching there. You can see on your slides the red dots. And how do you check the occlusion? Of course, in your age and your colleges, you use articulating paper, but one can have, digital also. So this is what, the occlusion function masticity muscle depends on the harmonious relation between occlusion and TMJ, and a relationship which is critical concern for diagnosis and treatment planning. Friends, any patient coming today, we first check that. And whenever I see there's a problem in the occlusion, the first thing I do is I press this muscle. Paining? Ouch. They say, ouch. I said, this is because of your teeth. And I just leave it like that. They don't understand because my teeth. I said, yeah. What is it? I said, I'll tell you later. What's your problem? My problem is second molar problem. So we check the second molar, we treat them properly, etc. But I have put a bird in their mind that there is a problem into their occlusion, their teeth are in malocclusion. And so we have to treat that also. So this is Occlusense, which is available with Bosch company, one of the less expensive digital occlusion. You have to check this with an articulating paper. This is with an articulating paper. So when you check, you can get the high point, low point, low point, where is the maximum occlusion. You can get all the points in digital way and the distribution of the points we can get. But this comes later on. Today you learn from your teachers and professors how to check the occlusion points, that the bullseye, what they say, that you can say, learn now, but this is the future. I'm just mentioning it to you. Never grind occlusion cusp, only grind fossas and marginal ridges. Keep this in mind. Working cusp, non-working cusp. There should not be contact in non-working cusp. So keep it in mind what to grind. Otherwise, usually what happens when you do tuck, 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 occlusal grinding. When you do a denture occlusal grinding, you grind the cusp. No, you are not supposed to grind the cusp. So this is what one has to keep in mind, the position and condition of this teeth. So these are the things which are. One second, let me finish. So the understanding of occlusion should not be limited solely to occlusal contact. The teeth are just part of total system. The position and condition of TMJs must be considered in relation with maximum intercuspation. Friends, this is very important, maximum intercuspation. So here you can see what exactly happens to the joint. So every aspect of the tooth position, you can see with the hormonal of the function, convexity, concavity. Even those dentists who are listening to me, or those who are doing crown and bridge work, have you ever checked your technician's carving on the palatal side of your upper anteriors? If this is over built up with ceramic, you have a problem. This is what emergence profile and incisal profile. This is very important for guidance purpose. And that's what one has to check in the mouth all the time. Canine guidance. The moment you take your jaw, everybody's listening to me, close your mouth, take your jaw to one side. It should be open, posterior open should be less than 0.4 seconds. And when you're moving this and something is touching here, that means you'll get headache, neck pain, shoulder pain, etc. That's the TMJ issue, malocclusion. So today, we not only check the teeth, we always check the muscles. That includes temporalis, occipital, masseter, sternocleidomastoid, trapezius. Because there is a malocclusion, the pain is not only here, it goes here, it goes here, it goes all over. And that is due to malocclusion. Now see this case. At the age of 22, you can see anterior teeth attridate, malocclusion. You can't get that attridate. So let's see a couple of cases of malocclusion before I finish. Maxillary canting related to interpupillary line. What is that supposed to be? This is what? This is Miss India in 90s when I didn't know about TNJ. When the teeth were going down, I did gingiectomy, alveolar that is CLP, and gave her composite laminates because she wanted to go for international contest. But if you want to see interpupillary line and incisal plane and gingival margin, look at her. So everything has to be plane, flat, parallel, parallel, parallel. That shows what? Interpupillary line, parallel to the occlusion plane, parallel to the nipple line, parallel to the hip joint, parallel to the knee joint, parallel to the sole. Friends, those who are practicing dentistry, if there are anybody is doing crown work in the mouth, posterior, tap, 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 adjust occlusion. Then we tell them incline position, make it straight. adjust occlusion. But you will be surprised, the patient goes out to the receptionist and tell them, when they are paying, they tell the receptionist, कुछ तो बीच में आता है, there's some problem, is touching first. And it has happened in all the practices. So we tell our patient, after doing this, we tell them to stand up and check the occlusion. You know why? Because if your soul is not parallel, occlusion will also change. Isn't it funny? Friends, God has made our mouth such as that it can it can let you know what's happening in the whole body, which is very, very, very important. So that's what is the occlusion, which is very important to understand. See this case, parallel, incline. So what was happening? Intercuspation was there. But what was happening? Touching first and then closing. Touching first and then closing. So what was happening? The muscles were acting funny, muscles were acting extra. So when we did a splint in the mouth, this side is more thicker than this side. So I'm sorry, thin here and thick here. The moment it touch here, we add some material on this side so that when the parallelism of interpupillary line with the occlusal plane takes place, then you decide to do either restorative or ortho, etc., etc. But this is a removable appliance to get your parallelism and occlusion, which is very important. Curve of Spee, which has been taught to you, but the important aspect of curve of Spee is that it passes through the condyle. But the unfortunate part, our Dental Council of India, I was a EC member, is today, whenever you do anything, 3-point articulator and we move the maxilla and not the mandible. So now MDS prosto, they have to get semi-adjustable articular where you should know that curve of Spee is passing through the condyle. So this great star, we told her, if you get only upper teeth out, our curve of Spee is damaged. So curve of Spee is not going through the condyle, you get TMJ issues. I'm not responsible. So we have decided to send a WhatsApp message so that we keep that message with us as a consent that we have told you. And if there's any problem, you are responsible. So let's see the next one. Open bite and deep bite. Definitely problem in centric relation. So let's take this deep bite case. There's an interference. Deep bite means I want to move the mandible, is not coming out. This is a problem. Here there is no, it's in group function all the time. So this was a case who came to us, said, I want laminate veneers. I want to go in movies. And I checked her bite and looked at her eyes. Her eyes looked tired because of malocclusion and clenching her teeth at night. Look at her neck. The neck has come forward. When the neck comes forward, the occlusion changes, your anterior teeth touches. This is what was happening. So this was a smile, and look at the anterior teeth. This is attrited. Even if I do laminates year and year, she will definitely fracture. Because the causative factor was the muscles of mastication and traumatic bite. Unless you do this, your occlusion is not going to come forward. So this was her bite. So we went into ortho. See, this was a joint. She was closing her mouth with the jaw forward. This was a problem she was getting. This was what she was post ortho, and you can see this has come out. Very nice. Another case, anesthetist from a hospital. We did the same thing. We opened the bite, did provisional restoration. Her headache went away. She had a lot of headache. Her headache went away. And then we did, this was a composite temporary laminates, and then we did ceramic laminates. Today, for last 6 years, she is not having headaches. That doesn't mean that you have to do laminates to relieve the headache. It was ortho which was very important. Now I'm showing one video, and I hope you get to see. If you don't get to see me, the host should tell me that he's not getting it. Now see what this guy says. He came to us wanting to do fast work laminates. And what I told him. Hi guys. Can you hear? So well about Dr. Mayekar.
Yes, sir.
Yes, sir.
Spent this year because the first year he's operating as a doctor. But I don't know how many of us know actually, but
so passionate about his work, which I found out when I met him for the first time. So I remember when I went up to him, my team, and I told him that I want gaps. I want to make like in a shortcut way. And but he is kind of doctor who told me you should not do gaps. First, it's expensive. Second, it's not natural. He would have made for the money from me, but he asked me to do the natural way, and he asked me to do braces, which I was really worried about because I thought it would be long process, paying, and that exactly happened. I went up to him after doing a braces, and I gave him a offer. It's detailed details and how to have a shoe coming up, and I really can't take it. Then he motivated me. But so he told that large spare within 2 days, and I think that's exactly now. I really want to thank him that I listened to him, and that's exactly what helped me.
The point to tell you is what? Diagnosis is most important aspect, causative factor of malocclusion, and then treat the patient. It's not that I'm orthodontist, so I do ortho, I'm not orthodontist, I do laminates. No. Today you got so many MDSs, and those students who want to do MDS, they should stick on to MDS. They should not change and do general practice. A lot of general dentists require MDS. And I'm going to market for you people. The specialist is needed in every clinic because a patient nowadays don't want to know that how good Dr. Mayekar is in his work. They want to know how good he is in diagnosis and treatment planning and getting the work done properly. And to get the work done properly, I should know occlusion, I should know everything. I did not do it. So they ask me, why can't you do it? I tell them that orthodontist has got specialized equipment, instrument. Oral surgeon has got different instruments. So that difficult cases, I don't do it. Certain things I do. Just now I'm talking to you. You must be wondering what I'm wearing. I've developed something called DPE. This is called DPE. When I come wholly on the screen, I'll show you what it is. So my staff is working. One guy is taking implant impression. Other guy was doing crown preparation. Simple, I was doing LC light core filling. So point here is holistic approach, collective work, best treatment for your patient. And that should be the agenda for us. So friends, now this is a case which is so funny, and this case came to us, and if you read my book, first chapter, he wanted to suicide. And the reason for suicide was 16 hours a day there was some sound in his ears. That evening, I had to go to Nasik for lecture. Well, and you will be surprised that lecture was from 9 o'clock and which finished at 2 o'clock in the 1:30 in the morning, and all the dentists were listening. So I was leaving in the afternoon at 3 o'clock for Nasik. He said, no, wait, this patient. ENT said he has to come because he's developed a tendency for suicide. He is a chartered accountant having offices in Thane, in Mumbai, suburb of Mumbai, Thane, Singapore, and Dubai. So I said, okay, I called him up. And what was the problem? Problem was he had anterior bridge with open bite. So there was a malocclusion. So the first thing what we did was gave him a splint. You can see a splint here. That is called modified Farrar splint. That's what I learned from Tufts University. This is a splint, 3-point contact to balance his occlusion. The moment his occlusion was balanced, his pain went away. He started smiling. You can see the teeth were not visible here, teeth are visible here. So what we did was created a nice occlusion from malocclusion to perfect occlusion. So this is in the first chapter of this book. You'll get to know exactly what I did, how I did, and what was the treatment we gave is the splint. And the splint, when he wears the splint, how the occlusion changes, because muscles of mastication deprogram. That's called deprogramming of the muscles. Slowly they program. So you can get the jaw goes into centric relation with certain issues in the anterior teeth. So we adjust the bite, and then they give the restoration so that his restorations are perfect. So that's what we did for him. This is what he did. And this is what you can see the anterior. Got anterior guidance from open bite, lateral excursion. And now you can see that these 9 teeth were not touched at all. Upper, everything was touched to get into proper occlusion. So friends, the point to tell you here is that youngsters, I see the youngsters, I'm scared of doing full mouth rehabilitation, and there are a lot of youngsters who are just 4 years, 5 years graduation. Oh, doc, sir, I got 5 cases of full mouth. And I was surprised. What is 5 cases of full mouth? So what is the definition of full mouth? Sir, I did all the crowns. I said, no, definition of full mouth is, even if you do 1 3-unit bridge is full mouth rehabilitation, you are rehabilitated the full mouth by doing some malocclusion to occlusion by doing 3 crowns. So it is not doing all the teeth is full mouth. Is full mouth rehabilitation is doing something in the mouth where the whole mouth is rehabilitated. So here if you see, the 9 teeth are not even touched. I could have earned more money. But your heart has to be satisfied that, okay, I've saved his teeth. And that is what is very important. Face-bow articulator is most important aspect in practice. Most important aspect in practice. The moment you buy chair unit and start your practice, buy face-bow articulator. It's like mirror probe tweezer and face-bow articulator. Because that is required for every damn case. Because what do face-bow does? It positions your maxilla in the fixed way. And once you get a position of maxilla, then you can articulate mandible very well. Because maxilla is fixed, mandible is moving. So this is what happened, comparison. Intraoral adjustment needed to meet the treatment goals, efficiency of the articulator. You can see non-adjustable, you spend so much time. And in adjustable, you can spend very less time. And that's what it happens in your practice. This is a case again, full mouth rehabilitation by implant prosthesis. And he said, Dr. Mayekar, I'm getting pain all over, headache, etc., etc. Now, this guy, to change all of them and do it new, he was ready. Looking at this guy, don't feel that he was like middle class and all. He owns the property near Mumbai, which is about 400 crores. But what we did was we gave him the splint. First, I told him that let us relieve the pain by adjusting your TMJ, centric relation, and we gave him the splint and his pain went away. So he said, now replace. I said, no. He said, why? I said, to replace all of them, how much torture will go? I will earn a couple of lakhs of rupees. How much torture will go? And then after that also you have to check the occlusion, etc. This you have to wear at night like a specs. I wear the specs. I don't wear the spec. I can't see properly. I wear the spec. I can see properly. He comes every 3 months. He's very happy. So when you give happiness and treatment to any patient, a human being, without damaging further, is the best treatment you can give to a patient. So this is what we gave him, and he's very, very happy. So friends, occlusal disease, signs of occlusion disease almost precede symptoms. The severity of structural damage is routinely progressive if not treated. That means what? Diagnosis of the signs are more important than diagnosis with symptoms. Once you know the symptoms, patients are telling you what the problem. But if you can see beyond the symptoms, the signs which are going to create symptoms, you become a good dentist. So occlusal symptoms, occlusion signs, you have to check first and explain the patient. So that is why I say occlusion is dentistry and dentistry is occlusion. So friends, thank you very much. I finished, I think, exactly in 1 hour. Yeah, 1 hour. That's the time given to me. This is my email ID. You can send my email to anybody. This is my family. My elder daughter is a dentist working with me. My younger daughter doing some apps. She is educated in London, molecular biology and public health from USA, Columbia. She actually came back to do my Healthy Smile NGO work, which we are doing it. I got a dental van. and we check lakhs, 3-4 lakhs of students in Maharashtra today, free of cost from our NGO. She looks after that. Now she's doing app for something else, which is very big thing. My only one wife, she's a chartered accountant by profession, but well, I don't have to think of finances in a sense. You know, she's the first thing after marriage. She said, "Pay tax." I said, "I got married to you so that I pay zero tax." But I realized that paying tax is also very important. And then my mother, she's with me now, 29 years. She was in USA with my brothers. Now she's back home, and I look after her. And let me tell you, friends, you all the youngsters, the biggest blessing a child can get is to take care of to take care of your parents when they are old. You don't need God also. And the last statement, friends, you know, you go to temple. I showed my Ganesha. If somebody goes to mosque, church, Gurudwara, why do you go? You must be going at this stage, अरे यार मेरे को pass करो like 3 idiot में नारियल लेके आओगे मुझे pass करो first BDS, second BDS, third BDS. No, friends, we go basically for peace of mind. And what is peace of mind? Basic luxury in life. So what is basic luxury in life? There's roti, kapda, makan. So God says, who are you? Says, I'm a dentist. Okay, I'll come to you as a patient. So friends, patients are next to God. Never cheat them. Even those patients who come to your college, they allow you to work and experiment in their mouth. Be nice to them. And that nice habit with patients develop properly. It's a habit called body memory. And subsequently, you can develop that habit with all the patients, whether it's poor, rich, or something. I've been always asked a question, how you treat the celebrities, how you treat Lata Mangeshkar, how you treat this person, how that. I said, I don't treat the person, I treat the tooth and the disease. And that is very important. Don't be personal bias, who is who. When Prime Minister comes to my clinic, I look at the teeth. Outside my clinic, he's Prime Minister. Inside my clinic, he's my patient like any other patient. So, friends, that should be your attitude. That patient who comes on your hospital also is next to God. Be nice to them and develop a nice habit. Always be concerned with them. So, friends, that's in short about occlusion. I don't know how much you understood, but that's what I want to share with you. And then, well, we can ask questions, or when you become big, you can learn about it. Thank you very much. Thank you.
Sir, thank you so much. I think every budding dentist should hear this lecture. And it emphasizes so much on why we study what we are made to study in the course. And honestly, sir, I had an eye-opening moment at every slide. Like every line you said, I was like, oh, okay, that's why. So I think your passion and bhavna pochhle, sir. So yes, and it gives us a reason to study better each day. And because most of us are stuck in the lockdown, we're stuck in a rut, and this really motivates us to do what we do with precision. And because now we know it affects everything, and I think this lecture should be given to every uh, when we enter BDS, like before starting the first year, and that occlusion is dentistry and dentistry is occlusion. And I feel so fortunate to have heard this lecture from you today. And we've not started clinics yet, and we're just doing theory, and this
No,
will
I
just
just want to show you. I just want to show you what I prepared. This is my what we call DPE, Dentist Protective Kit. That's what I made it. So I've got like PPE up to here. Then I got this up to here. Then I got a hood. So I put my hood like this. Then I put my double mask and the shield. So I'm protected completely, but I look smarter because it's not that typical bulky DP. This was designed by National Institute of Fashion Technology students, and it took long time, but they designed it well. Now a lot of my friends want it, so we are discussing to give them. And this is the opening change, complete opening, so you can close it properly. In fact, DY Patil, Mr. Vijay Patil asked me, Sandesh, what you prepare? Let me know. My students, you people can have this. You can have only 3 or 4 of them, and you can wash it every day, and you can use it again and again rather than using that. So I'm going to promote this to Dental Council of India to tell them people can have this. It's not very expensive. It's like your scrub, but following PPE norms that no virus should get in, you follow that norms, you can work peacefully with this. And let me tell you, when you go back to your clinic, the only issue is that you don't know your patient whether they are carriers or not. In our practice, we know that patients are that. So we also suggested the dental college people that they should do some testing. Something should be done that we know that there are no symptoms, etc. But I had COVID. I went through COVID. I gave counseling to COVID. I gave a webinar on COVID. Let me tell you, just smile with COVID. एक बार होना है तो होना है. Just don't get feared about COVID. You should listen to your body, and if something is little here and there, immediately think of COVID and take the blood test, not the swab test. Blood test. Swab test करके क्या फायदा है? Blood test to see what parameters have changed and start treatment accordingly. And then you can do, if you feel the parameters are towards COVID, then start for COVID. I tell you, nothing is going to happen. You have to stay with COVID, no fear, keep the distance, and use the mask. Mask, hand should not touch it. There are only three things. You get it through nose, you give it through mouth, and your hand touching here and there, when it touches the nose and the mouth, you can get it. I got it through my grandson. He was a carrier. He got it somewhere, but his nose was flowing. I didn't know till I saw the webinar. That in webinar, they say that small children are carriers. They don't get COVID disease. They only have got coronavirus. 2 days he was fine. 3-4 days after that, I got the symptoms. So if you read ADA reports also, dentists don't get it from patient. And I was asked the question by Mr. Dr. Agarwal from Delhi. He takes every day 7:30 something. And he asked me, how come medical practitioners get COVID and not dentists? I said, sir, we are born with the mask. We wear the mask all the time because that time that was a smell issue, halitosis. But today, that mask has helped us. I was just looking for a mask. I don't have it here. That mask has helped us to wear it. Without mask and without gloves, I can't work. When I finished my BDS, 77, 78. The first job I got it in a public hospital, which was a TB hospital, and I used to do 75 extraction a day without gloves. Today, I can't imagine that I was putting hand without gloves in the mouth. Forget about having blood all over. So today, once this norm comes in for you, you will not practice without DPE, dentist protective equipment. PPE is protect, prevent is essential. DP is dentist protective equipment. And that's what you should have in your practice. And bindas kaam karo. Dentist is the best profession. Nobody is going to die as a dentist. But those who say dentistry is a bad profession, they are not a good dentist. They don't have guts to work. Their hands are not like artists. They blame people. Don't blame. Ask yourself whether you can work in the patient's mouth. Just a simple example, I go from my one clinic to other clinic. On one corner, there are two hajams sit on the footpath. And I look at them. Every morning I see 3, 4, 5 patients, 5 people they do. Minimum 50 to 100 rupees. Multiply by 10, 1,000, 1,200 rupees. Multiply by 25. So he's on 25,000 rupees sitting on that roadside. And a dentist can't earn is absurd. It's total absurd. You read my book, I come from a very poor family, but my focus and passion was that. So anybody, as you people, well, my suggestion to ladies especially, don't jump into practice. All gents and ladies should not jump into practice immediately unless you understand not only occlusion, but understand human nature. And a Rotaract, definitely you do a lot of camps and understand human nature. And as females are concerned, do not start your practice till you get married. The reason being, you have to decide what to do. Your post-graduation also has to be well organized in a way that you should know that which branch you love to do, not just to get degree. Nobody asked me, I'm oral pathologist. Nobody asked me, you're oral pathology and doing this. So tomorrow I'm going to tell why oral pathology is important to do MDS. Oral pathologists ask me, sir, nobody's joining MD as oral pathology. I said, they are fools. I'm telling you, you know what is the private rate for oral pathology? 2 lakhs, 1 lakh. Join it. Why? Because you understand the microscopic structure of all the mouth, etc., soft and hard tissue where you can treat everybody. So when I learned etching bonding, when I did aesthetic dentistry, I could see dentinal tubules so big. So oral pathology gives you the inside story of everything where you can work and understand well. So, well, and then do general practice, which is up to you, friends. Now, if there are any questions. If there are no questions, we can end the session.
So we don't see any questions.
I hope they understood what I was talking about. You can ask me on anything, not only occlusion. You can ask me anything. I got 10 minutes with you. You can ask me anything. If you have any other program, you can stop it here. But that's what I wanted to tell you. Besides, I give lectures, motivational lecture. I give lectures to first BDS people before they start. But I also give lectures to colleges. They have invited me to give lecture after graduation to let parents know that graduate होने के बाद तुम्हारा लड़का पैसा नहीं कमाने वाला है. It will take time because medical profession, when you are young, you are the base of the graph. When you go older, you become top. When you are in the young as an art film star, you are at the top. When you become old, you come down. So it's matter of understanding the subject and reputation. Don't do wrong job. It's better not to do a job than to do a wrong job. Okay, so I gave you an email ID. Anybody wants to message me, and
So
good.
I wanted to say that what you said about Rotaract and talking to everyone and learning things, talking to like in the camps, like when we spoke to little children and everything, yeah, that definitely enhanced our soft skills. And also what you said about going to colleges, I remember the first day of college, you were there to tell us about dentistry in MGM.
Okay.
Yes, sir. I wanted to ask you, did you also know that you wanted to do dentistry and then TMD? Sorry.
I didn't want to do. I didn't even know there was a dental college when I joined dentistry. I wanted to become. My family member said you become a doctor. I said okay. So I applied for medicine, dentistry, homeopathy, Ayurveda, Unani, veterinary, OT, PT, सबको apply किया. I got in dentistry. When I got in dentistry, but that time also वो अपना कुली नंबर 1, जोड़ी नंबर 1, हीरो नंबर 1 बाद में आया. लेकिन that time I also had in my mind मैं boot polish वाला बनेगा तो भी नंबर 1. The problem with youngsters, problem in your generation is you compare with other people, other professionals. अरे वो कितना कमाता है, वो कितना कमाता है, वो कितना ऊपर गया. अरे यार तू डेंटिस्ट है ना, तो डेंटिस्ट के साथ कंपेयर करो because that's your line. So I was focusing on dentistry. I didn't have, if you read my book, I didn't have money to go for a movie with my friends also. So I should do Rotaract work. So the point here is, so first thing is focus, focus, and focus on your profession, what you want to become. Then oral pathology in 1973, my elder brother went to USA of taking lot of loan. Then my 75, my second brother went. So 77, I wanted to go. So I left, wanted to go in 78. Then they said, no, there is a job for oral pathologist in America, $40,000 annually. So I did oral pathology because I wanted a job in America. But I did a nice clinical research. I did my thesis topic was diagnosis of oral cancer with different diagnostic aid, cytology, toluidine blue, cytology, histopathology. And I did a new technology called NMR, which is now called as MRI. And TIFI people wanted me to do a MRI probe, but I didn't have money. So I was working with dentists and I started my practice. Then what happened? TMJ 1999, I had a habit of visiting dental colleges. I visit even dental institutions. I told you now, he asked 50% yes, 50% no. First visit to New York City, I was staying in Queens at my friend's place. I went down. There was a Korean dentist. I knocked the door. I said, "I'm Dr. Mayekar from India. I'm a dentist. I want to see the clinic." He said, "No." I said, "Okay." Subsequently, in 1991, I used to go every year because my family was there. So 1991, I went and I knocked the door of Dr. Jeff Gollivion, president of American Academy of Cosmetic Dentistry. And I went to him. I said, "I'm Dr. Sandesh Mayekar. I've started a new academy. I'm from India, blah, blah." He looked at me for 5 to 6 seconds. That is long time. And he said, "Okay, you can move around. You can observe me." And when he came down to India in 92, he said that I don't allow anybody, but I looked at him and I said, "Okay, he looks like my brother to watch." The point to tell you is ask. I don't know any of you. You ask me. I don't give so, like I'm not, I stopped giving webinars nowadays. People are very bored of webinar. So you asked me, I said, "Okay, Rotaract hai to de dunga lecture." So point is asking and doing. So that's how I get into. So TMJ, I went to Tufts University in 1999 to Dr. Mehta, just to meet him. And I was observing him, people were having headache, neck pain, etc. and they were treating them. I said, "Noshir, I was told I was spondylosis in 1996, 97, but I think I have TMJ issue." So I went and checked and I wear the splint and 2000, 2001. In fact, 9/11 happened. My assistant was there. I came 5 days early, 2, 3, and 4. After going every year for 2 weeks, 4, the dean had come to my house when he came to India and he saw my practice, etc. I introduced him to Miss World, etc. And then when I went back to meet him, they were discussing about MS course in TMJ and they had 5 students. So I said, "Me, sixth." He said, "You got such a good aesthetic practice." I said, "I'm not going to stop that. And I'm not going to TMJ practice because in India, nobody knows about it. I want to introduce TMJ in India. That's my job. And I introduce today. Today, everybody, every Tom, Dick, and I speak about so-called occlusion, mastery, this and this and this. I have done masters, and I'm only one guy who's done masters and practicing from Tufts University. There are people who are doing MSc and practicing. So what we do collectively. I do occlusion and muscles. I got a physiotherapy exclusive for TMJ, and I got neurologist. She's done masters. Dr. Ruchika Sood from she done the masters from New Jersey Dental School. So we work together. Friends, lastly, the point is very important that give the right treatment to the patient. And this particular headache, neck pain, no medical guy can solve the problem. Only if you know the occlusion, you can solve the problem. So we are now entering into medical field and telling them, "Hey, we are equal to you, okay? We are not down. Just because I got dentistry after medical, that is a wrong issue of NEET exam that dental and medical are together. Actually, dental should be separate, that there should be one question on art, because you have to be an artist to become a dentist. And that question has to be there. Just because I got 0.5% mark, you become medical top and we dentist. No. In fact, we know more than what you people, because we do medical subjects. You don't do anything in dentistry. So don't underestimate the power of a dentist. We know everything. So you should, medical people just look down at them. Okay, you, so what, you are medical. You don't save the life. You ultimately send it to ICU, now. The one specialist save the life. So there's no difference between you MBBS and me BDS. In fact, we are far better than them. So that's our profession.
Really elevates our confidence, sir. Thank you.
Anyway, so
There are two questions. Would you like to answer?
yeah, sure.
The first question is, how can we check if the masseter muscle is strong enough?
You can see it as strong enough. I mean, you can put your finger and bite. So it's the jawline. The jawline tells you the muscles are strong or not. That's the very important aspect. You can see some people cleaning their teeth. Of course, you can see the pounds. You can cleanse the teeth and you can see. The jawline tells me the masseter is strong or not. That's the jawline. You saw the Karina has got a solid jawline. There are few people who are very strong. The jawline is very strong. So the jawline tells me it's very strong. It's a clinical examination which tells me it's not a measurement of whether masseter is strong or not. Next one.
The next one is, why don't we place the third molar and complete dentures, and why only 28 teeth?
because we can't replace anybody's wisdom and अक्कल ना, किसी का अक्कल आप replace नहीं कर सकते ना. No, we don't replace the third molar because for retention purpose of the dentition, the extension of the flange which goes onto the retromolar pack, which is very important for retention. Because we require some suction in that area, and that soft tissue is very important. So normally also when we do implant, we actually go up to the first molar only and make a cantilever on the last one. Secondly, the chewing capacity of the third molar is very, very, very less compared to any other tooth. So there's no much use of the third molar. So we don't usually do that, replacement of the third molar. But if the third molar we don't remove the third molar unnecessary unless there is no opposing tooth, and that's going to change the position and cause problem to the second molar.
Okay. Participants, would you take a screenshot with sir just once?
So put me
I would
full
like to switch on your camera.
So put my hood up like Gully Boy.
Sure.
Yes.
Just to make it interesting, if you all would like to switch on your camera.
This way. What do you want me to do?
So it's a big deal for us.
Sorry?
Deal for us, right? Because you're the celebrity dentist.
No, I'm fine here. Okay, is that fine? You got a shot?
Yes, sir. Yes, sir.
Chalo, all the best to all of you. Hope to see you some other place some other time. And follow all Rotaract rules and Rotary rules, okay?
Yes, sir.
Okay, take care.
Thank
Bye-bye.
you so much, sir. Thank you. Bye.
Thank you, sir.
Guys, I hope you all have filled the feedback form.
Everybody's leaving. Nobody's listening.
I know. Do it.
Did you fill the feedback form? Okay, I filled. So, yeah, you were saying something.
Nothing. I'm saying that it was there were less participants than I expected. That's it. Okay, come. Let's decide the hackathon winners.
Yeah, okay. We'll hang up over here. Chalo.
Yeah. Bye.